Good morning, everyone. At the outset, let me thank Dr. Rajan Ravichandran for giving me this excellent opportunity to be with you this morning to talk about hypertension. And I am really overwhelmed the way in which Dr. Sundar was trying to praise me. Let me now try to talk to you about hypertension. Hypertension is a major risk factor for cardiovascular morbidity and mortality. We know very well that it leads to stroke events, heart attacks, heart failure, renal failure. In addition, one should not forget that uncontrolled hypertension can also lead to aortic dissection, an acute form of emergency, peripheral arterial disease. In addition, atrial fibrillation may be yet another complication which will probably push patients with hypertension for stroke events. One should not forget about dementia. Uncontrolled hypertension in people who are middle-aged can also lead to the complication of dementia. So never forget to think about that even in middle-aged persons with an uncontrolled hypertension, leave alone the elderly population. Death occurs if hypertension is not detected early, if not treated appropriately. With this introduction, let me now try to take you to the WHO publication. In the year 1990, it was projected that the prevalence of hypertension globally was about 650 million. In 2019, it touched 1.3 billion, nearly doubled. In addition, we are also encountering a big problem of morbidity as well as mortality in our country. The prevalence of hypertension projected by WHO is around 31%. When you look at this projection, which was actually in the year 2019, people predicted what is the prevalence of hypertension, how people are diagnosed, how people are not treated, how many people are taking the problems of the treatment, and how many of them probably leaving the treatment, and how many of them having a good control of hypertension. This slide gives you an information about it. 59% of the people are diagnosed, or leaving 41% of them not diagnosed. And 59% who are diagnosed, 12% are diagnosed but not treated, and 47% are treated, and 24% treated but not controlled. Finally, you end up only about 23% who are having a good control of hypertension, having got treatment. The most recent data that got published is ICM or INDIAP study, which had evaluated not only the prevalence of other non-communicable problems, focusing attention mainly on diabetes, but they also looked into the prevalence of hypertension. The data that was collected by the investigators clearly indicated that the number is jumping to 35.5% as far as hypertension is concerned. Taking into consideration 140/90 is a cutoff value beyond which one probably can say that the person is hypertensive. If you try to follow the American College of Cardiology and American Heart Association recommendation of a threshold to diagnose hypertension, 130/80. If that is followed, probably we will reach the level of 66% in our country. That is the magnitude of the problem of hypertension in our country, ladies and gentlemen. Please remember this. When you look at the mortality, as per the data projected here, nearly about 10 million people die every year due to uncontrolled hypertension. I think Amit Shah was very clear in telling that we lost only about 2 million people during COVID period, but look at the number of how many people are going to die when they have an uncontrolled hypertension. Nearly 10 million people die every year. Again, that's the magnitude of the problem regarding mortality due to uncontrolled hypertension. Having seen this, I should tell you that hypertension, which is uncontrolled, high systolic blood pressure, responsible for half of all cardiovascular deaths. It is linked to approximately 62% of the deaths due to chronic disease. It also affects about 80% of the people who are from low or low middle income countries. And that's again another big issue which we are now facing in our country. If you look at people with hypertension, they also suffer from diabetes. They also have a problem of dyslipidemia. In addition, if you look at, most of them are overweight or obese. If you look at population who have only diabetes, you also see that they are also having simultaneously yet another problem, that is hypertension. It is also not uncommon to see people with diabetes having dyslipidemia. In addition, if you take only population who have presented with dyslipidemia, significant percentage of them also have concomitant hypertension and concomitant diabetes. But we need to remember one important message, that the overweight and the obesity is playing the central role or the pivotal role in pushing patients for these complications, which are probably a lifestyle-related problem, which are commonly occurring reversible cardiovascular risk factors. If you have all these combinations, ladies and gentlemen, the problem of cardiovascular risk increases to levels more than 400 to 700%. I always feel when you have problems of hypertension, diabetes, and dyslipidemia, they are considered as a partners in the crime of pushing patients for an atherosclerotic cardiovascular disease early in their life. It is about the pathophysiological determinants of blood pressure and primary hypertension. The environmental factors do play a role apart from the genetics or the epigenetics. In addition, you also have a social determinant which also play. They are all interlinked for the pathogenesis of hypertension. I need to tell you that we were sincerely following European Society of Hypertension guidelines. We were following the Hypertension Society of India guidelines. But I need to tell you, 2017, the ACC-AHA came out with the guidelines which changed the scenario of our approach in managing hypertension by just diagnosing it properly. In fact, when these guidelines were published, there was about 14.8% of people in the United States become hypertensive on the next day itself. So they brought down the levels. We had seen people in whom the diagnosis of hypertension was made when they had the blood pressure of 160. Then it was brought down to 150. JNC 7 started talking about 140, 140. Yes, still we believe in our country 140 and above is considered as hypertension. Not only the Indian guidelines, the European guidelines also say. But there's a first guideline which had partnered with about 11 organizations, not a single organization, who came out with the data that 130 and 80 should be considered as hypertension. So the very simplified way of diagnosing hypertension. What is normal? 120, 80. What is abnormal? If it goes between 120 to 139, 80 to 89. These figures were identified by the earlier recommendation by the JNC 7 as pre-hypertension, or I call as a pre-diabetes. The same with the pre-hypertension terminology was introduced by the JNC 7. The same thing is now split in two groups. One group is 120 to 129, still the diastolic pressure is less than 80. The other one is 130 to 139, but the diastolic pressure goes from 80 to 89, which Americans call as stage 1 hypertension. When you reach 140, 90, what we consider as hypertension here is stage 2 in America. So that is the problem what we are now witnessing. Ladies and gentlemen, I like this definition because the pre-hypertension group has got an increased incidence of cardiovascular risk, not only in morbidity, but also in mortality. Taking that into consideration, I think we are fully justified in at least having this information that one need to diagnose hypertension when it crosses the level above 130 and 80. I don't like the definition of European Society of Hypertension, which gives you normal, optimal, stage 1, stage 2, stage 3. I don't remember the numbers. In spite of the fact that I had been in the field of hypertension for some years, I don't recollect also. And I'm not bothered to do that. But whereas recently, last year, people have come out to the staging of hypertension. That attracts my attention. Stage 1, uncomplicated hypertension without hypertension-mediated organ damage. There is no diabetes, there is no CKD. That's stage 1. Stage 2, there is a presence of hypertension-mediated organ damage, diabetes, up to stage 3. Then the stage 3 is the presence of cardiovascular disease, presence of CKD 4 or 5. That is stage 3. This staging, which has come out as a recent recommendation by 2023 guidelines of Europe, probably attracts our attention now. they had also come out how to initiate treatment for hypertension. Ladies and gentlemen, the one message that I would like to tell you, never treat a patient with an established hypertension with a monotherapy. Always go for a combination of drugs. Monotherapy is reserved for people who are elderly, people who are very frail individuals, people in whom we have so-called the elevated blood pressure, in whom the risk is high, but you need to give only a small dose of tablets, you can do that. The rest of them need to take only combination of drugs. This combination should be in the form of a single pill. Instead of punishing the patient to take one pill in the morning, one pill in the night, give him the combination in a single pill where the acceptability comes, the compliance becomes excellent. How to start the treatment? The drugs that are available with us, ACI, ARB, CCB, diuretic. Take either one of that, ACI, ARB, combine it with the CCB or a diuretic. You can go for a single pill with a true drug combination. Fellows not responding, go for ACI or ARB plus CCB plus a diuretic. Give 3 drugs in a single pill combination if possible. Fellows not responding, most of them will respond. Please remember, because you have an inhibition to treat your patient. The fellow comes with a 150 by 94, you tell him, okay, next month we'll see, don't worry. You try to keep the same dose. The fellow is comfortable, he laughs, he keeps your fees, gets out. Probably he may end up with a complication of a heart attack or a stroke after 2 months or 3 months when he is not going to report to you because you have already given him encouraging words. That should not be our approach. Try to treat him aggressively so that you reach the blood pressure as early as possible. You start treating patients, you need to bring down the blood pressure within a matter of 3 months. Please remember that. There is evidence. I am talking about evidence. Within 3 months, if things are brought down, you reduce the risk of cardiovascular problems, including stroke, including heart attack or heart failure. That has to be adopted in our clinical practice. Those doctors who have responded to our invitation should remember that they should give combination drugs. They should bring down the blood pressure as early as possible, at least within a matter of 3 months or so. Finally, when you look at the patients who are having so-called resistant hypertension, it is only about 5% or 10%. Those people only require the other drug, like spironolactone. There is an interest to talk about the diuretic. In fact, JNC started talking. The first drug should be only diuretic. But now, the ACC in 2017 told us, you can choose any drug. ACI, yes. ARB, yes. CCB, yes. Diuretic, yes. Any one. Combination, it is left to you. You choose a combination, give it to your patient. That's all. Very simple way of managing hypertension. That was a message what we obtained in 2017 guidelines. But I need to tell you, there is a lot of interest now in the recent past about the management of hypertension by using diuretic. The chlorthalidone is a thiazide-like diuretic which had been shown to reduce the blood pressure, reduce albuminuria in uncontrolled hypertension in CKD 4 stage, and when it is added to the drugs which are the patients taking, at the same time, many of them are on loop diuretic. This last month, 19th of May, this got published in JAMA about the role of chlorthalidone compared to hydrochlorothiazide. Those doctors who are seated here probably be wondering whether I can use hydrochlorothiazide, whether I can use only thiazide like diuretic like chlorthalidone. Here is the data. The data clearly tells you that those people who established atherosclerotic cardiovascular disease, the primary outcome came down when they started taking chlorthalidone compared to hydrochlorothiazide. The heart failure rates came down. The hypokalemia slightly on the higher side but not statistically significant. And then the acute myocardial infarction incidence came down. And then the non-cancer deaths came down with the usage of chlorthalidone. The final conclusion by the investigators, the CTD associated with reduced adverse CV events and non-cancer deaths compared with hydrochlorothiazide. But the investigators were not able to give any explanation why non-cancer deaths are coming down in chlorthalidone. This is yet another study. I will not dwell into these studies because it will be boring. This is Fedilo DKD study where it was conducted in people with the diabetes with the chronic kidney disease, where they have administered a drug called finerenone. It is a non-steroidal mineralocorticoid receptor antagonist. That drug was used with 10 milligram to 20 milligram, reduced the albuminuria, reduced the blood pressure, and made good amount of reduction in the cardiovascular risk faced by people with the diabetes, and CKD. Excellent study. People started using it. Now recommendation is for finerenone. Having seen this, I think the CKD, how to treat. Rajan Ravichandran, I am not able to see, but Dr. Sampath is here. This is a recent recommendation. I am sure you will also agree. Divide them into two groups. On the left side, you can see those people in whom the GFR is more than 30, the way of treating it. The other one is the GFR less than 30, where the stage is about 4 and 5 stage of kidney disease. The role of chlorothalidone comes on the other side. You can just see. Use the chlorothalidone over and above the loop diuretic. Many of them prefer loop diuretic all the time. But it is now time for us to take yet another diuretic to bring down the blood pressure in those people with the CKD. You may be wondering, okay, we have made a diagnosis, 140/90 in India, 130/80 in America. What should be the goal of blood pressure? You look at the data from the meta-analysis which had used multiple drugs in managing hypertension to reduce the cardiovascular risk. The data is very clear. If you are able to reduce the systolic blood pressure by 5 millimeter, reduce the systolic blood pressure by 10 millimeter, you can see the difference. Number of events of major cardiovascular events come down twofold down. The same way the stroke events doubled. The heart failure events came down by nearly about twofold decrease. Ischemic heart disease, twofold decrease. Cardiovascular death again decreased. So you have to reduce the systolic blood pressure. You have to reduce around 10 millimeters of systolic and keep the level between 130 and 80. You get the maximum benefit, not only in people with diabetes, without diabetes, with stroke, without stroke, with the CKD, without CKD, with the CAD, without CAD, with heart failure, everywhere you get a benefit by using this sort of information from the meta-analysis. I think you need to concentrate on that. I think the American Association had given one simple message, only one number you remember when you start treating patients. What should be the goal? 130/80. That's all. 130/80 should be the goal of treating any patient with the blood pressure. That should be the goal. So I need to tell you, there is a divergence in the recommendation to use antihypertensive drugs by categorizing the systolic blood pressure into consideration for diagnosing hypertension. 140 there, then somebody says 135/85, somebody says 130/80. Whatever is the divergence in the recommendation to diagnose hypertension, but all the guidelines are converging to one point. What is that? 130/80. Please remember that. The goal should be 130/80. Okay. Can we bring it down a little lower? Sprint trial has shown. This is called ESPRINT trial, which has shown, ESPRINT trial, less than 120 systolic if you are going to get it and compare it with the people who had reached less than 140. What's the benefit? Benefit is there. So you can even bring it down. This is a recent study. Resistant hypertension, I will not go into the details of definition and all. Apparent resistant hypertension, apparent refractory hypertension, and true resistant hypertension. When you have a true resistant hypertension, there is a volume overload. There is an aldosterone excess. And then the refractory by enhancing the sympathetic care. These are the methods how you should manage resistant hypertension. One, lifestyle modification. I think I need to appreciate the previous speaker, the nephrologist from Mumbai, had given us lots and lots of information for you to follow, for you to preach to your patients, for the patients to preach their relatives, how they should adopt the lifestyle changes to make their life better. And then the second one is the RAS inhibitors, salt fluid retention, probably diuretics, arterial tone, you have calcium channel blockers, and then the step 3 is the device therapy, where you have a renal sympathetic system blockade, and then the central sympathetic system, arterial tone. When you look at this resistant hypertension management, which is true resistant hypertension, where there is a volume overload, where there is an increased sympathetic activity, in that case, what will you do? Try to use chlorthalidone, it is there, over and above loop diuretic, yes? The last one on this side, when you have a eGFR more than 40 ml in a patient in whom the blood pressure is not coming under control, whatever the drug that you have used, submit him for a renal denervation. That's the recommendation now. Please remember, renal denervation is effectively can be performed in those patients in whom you have an eGFR more than 40. Renal denervation, just look at this. You are cutting the sympathetic nerves, the efferent nerves gone, the renal blood flow goes up, sodium excretion is enhanced, shift from non-dipper to dipper, so perfect 24-hour blood pressure control by controlling the nocturnal hypertension. On the other side, the afferent nerves are blocked, so central sympathetic system activity comes down, baroreceptor sensitivity goes up, so the early morning surge comes down, and then the extra nocturnal BP surge during sleep apnea comes down. As a result, you are reducing on one side nocturnal hypertension, on the other side the early morning hypertension. So both can be controlled if you are able to get a successful procedure called renal denervation, which is now being recommended by the European Society of Hypertension. I don't want to dwell how things are being recommended. For more than 40 eGFR, you can recommend your patients for this procedure. Future is bright as far as the procedure is concerned. One, it can be useful for chronic heart failure, atrial fibrillation, ventricular tachycardia, sleep apnea, type 2 diabetes, and chronic kidney disease. I will take you to the recent drugs which are now going to probably reach India also soon, that is endothelin receptor antagonist. This drug, endothelin, is a powerful vasoconstrictor substance triggered by angiotensin II. Please remember that. That is A, B. Block A, it is AT1A blockers. Endothelin receptor B blockers, separate. If you have combination, drugs are available. These drugs were actually used mainly for treating pulmonary arterial hypertension. The one drug that was tried in phase 2 trial is aprocitentan. This aprocitentan now recently completed this trial called Precision study, which had forced the agencies to come out with a recommendation. Aprocitentan, ladies and gentlemen, is a newer drug, endothelin receptor antagonist, which has got both A and B. This drug is now approved for the treatment of uncontrolled hypertension. But please remember, edema can be a problem, fluid retention can be a problem. Can you use SGLT2 inhibitors in the management of hypertension? We know 2 to 3 millimeter reduction, 4 to 5 millimeter reduction by using SGLT2 inhibitor. There are a good number of studies. How? It can be due to osmotic diuresis, weight loss, improving the endothelial function, the blood pressure comes down. The next one is the RNA. RNA, I think that composition is sacubitril valsartan. Valsartan is A2, the angiotensin receptor blocking drug. So it will have an effect on the reduction of blood pressure. What about the sacubitril? It inhibits the degradation of natriuretic peptides. So the drugs have been approved mainly to treat heart failure. Mainly to treat heart failure. Not approved in our country, please remember, but Japanese had gone ahead of us. They are using it for controlling the blood pressure. Chinese people are using this particular drug, but still FDA has not approved it. In a recent meta-analysis which clearly indicated about 6,000 patients who were hypertensive, there's a good reduction of systolic blood pressure, both systolic and diastolic blood pressure, by using this particular molecule, that is RNA. So now some of the doctors with whom I had an interaction, including cardiologists, they are using this molecule in the management of hypertension, not approved by FDA. The novel drugs, vascular targets and endocrine targets. Vascular targets, you have age blockers, xanthine oxidase inhibitors, PDE inhibitors. Endocrine targets, aldosterone synthase inhibitors. This drug is now going to arrive in Indian market because it has not completed the phase 3 trial. The phase 2 trial, the dose finding trial, where they have used this drug in 1 to 2 milligram. In fact, it reduced the plasma aldosterone levels only and not the cortisol levels. Device-based therapy, baroreflex or activation therapy, carotid body ablation, central iliac arteriovenous anastomosis. All these procedures are all only experimental. Just for you to understand and for my completion, I have mentioned it. Pharmacogenomics, attractive field. Antisense oligonucleotides interfering with RNAs. Animal studies have shown promising results. Human studies is the cardia, where it stops the production of angiotensinogen in the liver by injecting this drug. It has shown there's good effect in reducing the blood pressure. In 2022, World Hypertension League came out with the recommendation that you should cut down the salt. No hypertension talk will be complete unless you talk about salt. Dr. Rajan Ravichandran mentioned this morning that he had seen in the newspaper. I had to go through the newspaper. I'm in a hurry to reach this place. Some cardiologists had mentioned about the management of hypertension without mentioning salt. 2022 World Hypertension League, with the resolve to save lives, had come out with the recommendation of to reduce the salt intake. I think with the salt intake, if it is reduced, you can anticipate reduction of blood pressure to the extent of 2 to 8 millimeters reduction. There is a recent study about the dietary sodium on blood pressure, which was released only last year, indicated that reduces systolic and diastolic blood pressure. Never ever forget about the DASH diet. Dietary approaches to stop hypertension. The good old dietary approach which has been recommended by various academic bodies, I think many of us did not concentrate on that. Many of us did not preach the students also to talk about it. I think it is high time for each one of us in this audience to at least to look at this figure and see that this figure probably attracts the attention of your patients when you hang it in your clinic. Artificial intelligence, I think Dr. Krishna Kumar will have a lot of interest in this field too, in the field of hypertension. I don't want to dwell here because of the lack of time, because other speakers are waiting. What are the future hypertension prevention strategies in India? People talk about obesity, metabolic syndrome, complications related to obesity and all those things. But at the same time, we are still having another problem, the other end of the spectrum, poverty, malnutrition, undernutrition, still going on in our country. This is my last slide. For any lecture on hypertension, I always show this particular slide because I like it right from the beginning when I started talking about hypertension. Look at the patient who is standing there outside the clinic of a doctor. He only inserts his arm into the hole there, asking the doctor to give him some tablets for the blood pressure rise, which he had experienced in the last 2 hours or so. He is in a hurry to attend some board meeting. Of course, he is drinking alcohol. At the same time, he is a smoker. He is an obese fellow with a metabolic syndrome. The doctor punishes him with a blood pressure apparatus, which is very old, should be discarded, mercurial manometer. He actually ties the cuff in the forearm, measures the blood pressure in a standing posture when the patient is adopting the standing posture, punishes him with some tablets. Both are wrong. Patients are wrong. The physician is wrong. So, ladies and gentlemen, let me have the pleasure of inviting you all for a World Hypertension Congress 2025, which is going to happen for the first time in India, first time in the city of Chennai, and which has been arranged in Chennai Trade Center. Luckily, I am the organizing chair of the Indian Congress Committee of World Hypertension League. They had given me the huge responsibility of conducting it. Those of you who are the doctors, even the non-doctors can also participate in this meeting because we are going to teach them how to measure blood pressure. We are going to have salt session. I think this will attract the attention of even non-medicals also. Thank you very much, ladies and gentlemen. Those of you who are interested, please just click it. You can browse the net and then look at what is the ideal fees that need to be paid till tomorrow morning. From tomorrow, it is getting changed. Thank you very much, ladies and gentlemen, for patient listening.